Welcome everyone to the Evaluation and Management Data Questions and Answers webinar. My name is Ellen Barra and I'll be your presenter for today. On the call also is Rachel Wood, and she'll be monitoring our chat function, adding some additional information into the chat for you. This webinar today is designed as a question and answer. We have been doing a lot of evaluation and management webinars, and these are all available within our YouTube channel. Some of them are probably still available on our website. You go into the training center, and then there's a section for encores. On the YouTube channel, this is in the Encore playlist, our previous webinars, and in the Evaluation and Management playlist. We are recording this presentation today, and we will be adding that to both our website and to our YouTube channel. So the first thing that we have for you is our disclaimer, and we use this with all of our presentations. This education is a tool for you, but Medicare rules do change often. CMS contains those rules on their website, the laws, regulations, etc. We'll provide responses to questions based on the question that's asked, but Medicare rules will, of course, determine final coverage along with your documentation. CMS does prohibit recording of the presentation for profit-making purposes. So if you are recording or doing screenshots, we would ask you to stop doing that. As I stated, we are recording this and it will be available on our website and available on our YouTube channel. So as we talked about, we have designed this basically as a question and answer for you. We are going to go over a few things within the presentation itself, but we want to respond to your questions. And what we're going to be talking about today is specifically the data element of the medical decision making for evaluation and management services. We did receive pre-submitted questions on other aspects such as the problem or the risk category. We won't be addressing these in the presentation today. We are holding a risk webinar on Thursday, and that is advertised out there on our website. If you've not signed up, you can certainly do that. We also receive questions on split and shared services, different categories of E&M services, and we do have encore presentations available, so we won't be discussing those here. The first thing is just a reminder for you that all services do have to be medically necessary. And what that means is that documentation shows that the services are reasonable and necessary for the diagnosis or treatment of illness or injury, or to improve the functioning of a malformed body member. The American Medical Association made drastic changes in the description of the procedure codes and in how you choose your level of service. For office or outpatient services, those were effective January 1st of 2021. For the other categories of service, that was effective January 1st of 2023. You'll choose your level of service based on either time or medical decision making. And medical decision making is the problem, the data, and the risk. There are two exceptions to that. Emergency department services are medical decision making only. Critical care is time only. So the categories of the medical decision making are listed here for you again. It also includes a medically necessary history and exam. And just as a reminder, an evaluation and management is a face-to-face service, which of course includes telehealth. The next slide that we have is just the categories of service. Again, most of them have 4 different categories. Some categories actually combine the straightforward and low. In order to meet a category, you do have to meet or exceed, or I'm sorry, in order to meet a level of service, you do have to meet or exceed 2 out of the 3 categories. So when we're talking about data, the straightforward level is minimal or none. And then as you continue up through low and the additional categories, you do have to meet a certain amount of what is required for that category. For the low level, you have 2 different categories within that element of the service, and you have to meet the requirements for one of these 2 categories. Under tests or documents, you must have 2 of the items listed, and this includes reviewing a test, reviewing notes from a unique source, or ordering unique tests, and we'll provide definitions of those in just a second. Also for the low category is the need for the independent historian. And again, we'll talk about that in more detail in just a second. When you get into the moderate, you still have to meet 1 out of the 3 categories, but under the test section, it now requires 3. For the high category, you have to meet 2 out of the 3 categories. For moderate and high, the independent historian has now moved into category 1, and we now have a new category 3, which is a discussion of management or test interpretation. And we'll provide a definition of that just shortly. For moderate, you have to meet 3 out of category 1, but you still only need to meet 1 out of the 3 categories. One of the areas of confusion seems to be a review of a test and the ordering of a test. When you order a test, the review of that test is part of the order. You would not count that twice. For an example, you order an A1C for the patient. You count that as the order. The analysis of that A1C result is part of the order. Another example, however, is that you see the patient in January and you order monthly INR testing. You count this once for the January encounter. The monthly INR is 1 unique test, and we'll discuss further on another slide. You see the patient again in June. You can now count the review of the additional INR tests. That would be February through June. Again, this is a unique test, so you would count this just once. So let's talk about some of the definitions then. Under data Under data analyzed, this is the definition from the AMA documents up on your screen. This goes back to proof of thought. The practitioner is reviewing or analyzing the test results to help determine the plan for that patient. When you see that patient in June, going back to our INR test results, you're going to analyze those, and that will help determine the plan. This could be keeping everything the same. It could be making adjustments. Presumed to be analyzed, this supports that you only order those tests that you need to determine your plan for the patient. Ordering more tests simply to meet category 1 requirements really is inappropriate, and we've actually had that question come into us. Not only would you be increasing costs to the Medicare Trust Fund, but also possibly subjecting the patient to unnecessary testing. And again, it all goes back to medical necessity. A pre-submitted question that we had is, does pulling the results into the medical note count as analyzed? Well, what we really want to see in that documentation is that proof of thought. How is the practitioner using those results in making that medical decision making for that patient? The next thing that we have here is the definition of a test. This could be imaging, laboratory, psychometric, or physiologic data. A unique test is based on the procedure code with one exception. If you have one procedure code that includes other services, such as a lab panel mentioned, then this is one unique test. All of those individual tests are part of that lab panel. So you would not count those individual tests under a procedure code. You can also see here that pulse oximetry is not considered a test. We have heard from some providers that this is used as part of the vitals that were taken for that patient, but you would not count it as a test. Category 2 for the moderate and high area includes an independent interpretation. This is similar to what a radiologist or a pathologist would do. You're looking at the x-ray or the slide and you're providing an interpretive report in your documentation. So you're deciding exactly what that test shows. You're actually looking at the film from that radiology service and you're making the interpretation for that. This is above the just a review of a test where you're looking at that test result and then you're making a determination. The American Medical Association states that if the ordering and performing provider is by the same practitioner or a member of the same group, does not count separately. So if your physician ordered and your group provided, and then your doctor interpreted and you're billing, then you can count that professional component, but you would not count it as part of your category of service. A pre-submitted question, can we count the same test multiple times when performing for different reasons? And the answer to that is no, not if ordered at the same time. It's considered the same procedure code. You would count once. Another pre-submitted question that we had is the medical record shows that the test is intended to be ordered, but there wasn't an order for that. You would not count this in this situation without additional documentation. So you need to show what was considered, why it was not ordered. It could be a situation where you're ordering for some reason happens a week or so later, then you could still count it as long as you've not already submitted that claim. If your patient comes in and asks you, I want to have a chest x-ray for whatever reason, I want to have an MRI, and your doctor is spending the time to talk them out of that because it's really not medically necessary, count that. As long as that documentation is there to support, again, that proof of thought, you can count that consideration. Same thing holds true on the other side. You consider a test, let's say an MRI, for the patient, but based on shared medical decision making, the patient condition, the physician's thought processes on that particular test, they determined that we're not going to do that test at this time. So you haven't ordered it, but your doctor has done the work on that. So as long as that's documented, then you can actually count that. Documentation would show the physician consideration and then why they determined not to order. The next thing we have up on your screen is the AMA definition of unique. So we've talked about a unique test, but now let's talk about unique in another aspect. If you review records from, let's say, the last 3 ER visits from ABC Hospital. This is one unique source. So it all came from ABC Hospital. So even if it's only one record or it's 15 records, that's still one unique source. If you're analyzing the testing from those same ER visits, you can count that as a separate unique source. I've placed a link where you can see this on the AMA website in our resource slides. This is not a review of your previous medical records. It's not a review of other medical records from physicians in the same group with the same specialty. This can include records from other members of your group that have a different specialty. And remember, Medicare views specialty as the two-digit specialty under which that practitioner has enrolled. For an example, the cardiologist is reviewing the medical record from the internal medicine doctor of the same group. This could count as a unique source. What about an encounter 3 days ago, and now the patient calls back and gives you additional information, and you order a test? This would not be for the encounter 3 days ago, but the review of that test then could be counted in that next encounter with that patient if the documentation supports that analysis. Up on your screen, you have the information from the AMA again about external defined. This is not reviewing your own previous notes again. This is coming from outside or a member of your group with a different specialty. We had a pre-submitted question. The nurse practitioner orders a test. The MD or the DO then sees the patient and reviews those test results. Can we count that? And the answer to that is yes, because they are different specialties. The next thing that we have is discussion defined, and this is part of category 3. This is a real-time discussion between the practitioners on that patient condition. So this could be the cardiologist discussing an aspect of the patient care with that internal medicine practitioner. It could be an exchange of information. As you can see in the description, it's not an exchange of notes within the medical record. This is two people talking to each other. Now you can use text messaging, you can use email, you can actually have a conversation, but it's a real-time exchange of information. This could be discussion of patient care. It could be a conversation with the practitioner who provided the interpretation of the X-ray itself to discuss the results if there are questions. Documentation would need to show that exchange of information and then the medical reason for that interaction. It does not have to be on the same date as the encounter. Now, Medicare would expect that the conversation would start on that same day, but the AMA information shows that it could begin on or right after the encounter. And then depending on the nature of the encounter, this goes on for several days. You would not actually count it though until you see that interactive response. So now we have for you what is required for data for the straightforward level. And you can see this is minimal or none, meaning that you have one piece of data that you ordered as opposed to meeting the requirements, or that there was no data that was analyzed or ordered for this patient. Now keep in mind what we talked about earlier in that you have to meet 2 out of 3 of the problem data or risk. So if you have a situation where you don't need to order data for the patient, that doesn't necessarily mean that your level of service is going to be lower. So what we have listed up here on the slide for you is the information from the AMA concerning the categories. And you can see here that there's category 1. And for category 1, you have to have any combination of 2 of the following. So if you ordered 2 unique tests for that patient, then you meet that category. And then category 2 is the assessment requiring an independent historian. Now, what you want to look at for the independent historian is this required, or is the wife simply helping the husband to provide information? So what your documentation would show here is why you needed what was the medical reason why you needed someone else's assistance there. So when we go into the category 1, we've already discussed the definition of unique and external source. The link on your screen shows a question and answer to support counting reviewing notes from an external unique source and then counting any tests as part of that unique source. This is not 2 of the 3 bullets, but 2 of the 3 items as listed. For an example, ordering 2 unique medically necessary tests. As we talked about, it is considered double dipping if you count both the order and the review of the same test. That review is part of your order. We had a pre-submitted question. You order the tests and you review the results. Your office is going to bill for the technical portion of the service. So we're talking a pathology service, a radiology service, something like that. Can we still count this as data? And the answer to that is yes, as long as you're not billing separately for that professional interpretation. The fact that your office is billing for the technical portion does not take this out of being a unique test. If your doctor indicates personally reviewed by me, can we count that as an interpretation? And the answer to that is no. The doctor is telling us by using that language that they have performed a review and not an interpretation. And then another pre-submitted question, if we're reviewing a prescription drug management program from 2 different states, can we count this twice? And the answer to that is yes, because they're 2 unique sources. But what you want to document is, what are you reviewing? Are you looking to see if it's covered, which in that case probably not, or are you looking to see what they have been on and how are you using that for your medical decision making? As we talked about independent historian, it doesn't need to be provided in person, but it does need to be obtained directly from that independent historian. And if you're using an independent historian, your documentation should support why you needed to do that. Notice that the definition states the patient is unable or unreliable to provide the history. A mom providing history for a child would satisfy this. For adults, indicate why the patient's history is not complete or reliable. The next thing we have now is for moderate, and we have 3 categories here. You must meet at least one of these 3 categories to fall within the moderate range. For category 1, we now have an independent historian moved into this category. Category 2, well, let's go back to category 1, and you have to have 3 of what is listed there in category 1. For category 2, this is the independent interpretation. And we talked about this one a little bit in the fact that your doctor, if they're doing an independent interpretation, is going to document that. So they're going to document their interpretation of that test result. Now, the AMA instructions state that it is not required to be at the level of the radiologist or the pathologist, for an example. But we do have to, Medicare would have to have enough documentation to show that it is an independent interpretation as opposed to a review of that particular test. And then category 3 is that discussion of management or test interpretation. We had a pre-submitted question on this, and it says if you talk to 2 different external physicians, does this count twice? Well, talking to one physician meets the category 3. So this would be talking to 1 or 12. You meet this category, you would only count category 3 once. So we've got some additional information here on independent interpretations. A clinical lab test would not qualify for this. This would be radiology, pathology, something like that. And then, of course, you would not be submitting that professional component. We are expecting some type of report within that medical record for that test result. If you're billing for the professional component, obviously you wouldn't count the independent interpretation as part of your data. We had a pre-submitted question. Can we count as an independent interpretation when the hospital performed a telemetry and our physician provided the interpretation? And the answer to that is yes, you can if you're not billing separately for that. We had another pre-submitted question. Can we count the same test as both reviewed and an independent interpretation? And the answer to that is no. You can count the order if it's happening at the same time, but you would only count, and then you would not count the review. But if you're, and you would not count the review and an independent interpretation. You would only count one of these. Another pre-submitted question we had was, can the non-physician practitioner document the physician's interpretation of a test? And the answer to that is no, unless they're acting as a scribe. The person who's doing that interpretation must be the one who's documenting that interpretation. So here we have some additional information on that discussion of management. Again, it's not simply notes within the medical record going back and forth. It's an actual conversation through text messaging, phone calls, emails, etc., between those 2 parties. You would not consider this met until the exchange has started and it has been completed. So whether it's asking questions about plan of care, asking questions about the interpretation of a test, something along those lines. You also have to be using an appropriate source. So this could be another practitioner. They're not in the same group with the same specialty, but it could also include a lawyer, parole officer, case manager. These are just a couple mentioned in the AMA documents. It does not include discussions with family or informal caregivers. That's just part of the work of the E&M. Your documentation would be the exchange of information. So you would document what you sent to the other provider, what they sent back to you, any follow-up questions, etc. A pre-submitted question we had is, would a quick conversation to ask if another physician would take the patient? Would that be an exchange or a discussion of management? And the answer to that is no, based on how the question is asked. If the interactive discussion was on patient management, hey, I've been doing this and this is not working. Do you have any suggestions? Should I refer the patient to you? That type of an exchange, then that could be counted here. You would need documentation to support that. The next thing that we have is high, and you can see we have the same three categories. From category 1, you have to have, well, for the high category, you have to meet at least 2 out of the 3. And then for category 1, you have to have any combination of 3 of the following. And then, of course, it has category 2 and category 3 are the same. So what we have up for you here are the resources. The AMA information, the link that is there takes you to the guideline changes that the AMA made. We also have the internet-only manual publication. The section 30.6 is really kind of where all of the E&M information is located. And then CMS has an MLN on evaluation and management services for you also. So before we open it up for questions, I do have a couple of additional pre-submitted questions that we'll talk about. So the first one is documentation for review of external notes and review of unique tests. How do you do that? Well, you need to identify what you have reviewed and how you use that information in your medical decision making. So let's go back to our example of ABC Hospital, and we have reviewed the notes from the last 3 ER visits and the testing that has been done. If none of that information makes any difference to how we're going to determine the plan of care, then you would not count it. If you're not using that, no, let me rephrase that. If you're not going to use that information in determining your plan of care, then you would not count it. If you're reviewing that information and the information does make a difference in your plan of care, either you're going to stay with exactly what your physician decided to do to begin with, or you're going to make adjustments based on the review of that information. You want to document that within the medical record. When providing a split or shared service, you're going to use the total documentation to show your level of service. So this would be documentation from both your MD or your DO and your non-physician practitioner. So you combine that information up to make sure you're meeting all of those categories. And then, of course, under the split shared guidelines, you'll choose under which practitioner to bill based on who provided that substantive portion. The next pre-submitted question we had is we reviewed notes from a recent hospitalization. We also reviewed the test results. Can we count this once since it's one external unique source, or can we count it twice? And the answer to that is you can count the medical record notes and you can count the test results. You can count that twice. Another pre-submitted question we had is the doctor reviews a culture every day since the growth may not be apparent, and so they're actually viewing this culture every day. Can we count each of those as a separate review? And the answer to that is no, it is one unique test. The last pre-submitted question that I have is the medical record says that the physician wants the patient's primary care physician to get an EKG. Can we count this as an order? So the question that we would have and what we would be looking for in the documentation is, are you ordering that EKG or are you leaving it to the primary care physician to determine? If you're actually ordering that EKG, then yes, you can count that. If you're leaving it up to the primary care physician to make that determination, then no, you would not count that as an order. So that's all the pre-submitted questions that I have. We'll go ahead and open it up now for questions in our chat. Rachel?
All right, so I'm just going to start at the top. So what is meant by external physician? Does this mean somebody outside of the clinic or just someone of a different specialty?
That's a good question. And when you're looking at external source, you're looking outside your clinic itself. You also, however, can use external source for a member of your group who has a different specialty than that provider making the request.
All right. For any test that requires an official interpretation and has its own professional component, so for example, an EKG, can a provider make the decision to count their independent interpretation under medical decision-making in lieu of billing for the professional component for the official interpretation?
That's really a business decision for your offices. As far as Medicare is concerned, you want to bill obviously for what you're doing, but if you're not billing separately for that interpretation, then you can count that as data. If you are billing separately, then you would bill the interpretation and you would not count it as data, but that's really up to you. Next question.
All right. If a provider documents that they reviewed the labs done in the ER during the same encounter, could that be considered review of external documents or review of labs?
Okay, Rachel, read that one to me again. I'm sorry.
Sure. So if a provider documents that they reviewed labs that were done in the emergency department during the same encounter, could that be considered review of external documents or review of labs? So I think maybe the person might be admitted after in this situation.
Okay, and that's what I was looking for there. If it's all part of the same encounter, then you're going to count those order for the test. If you're now seeing the patient later, either as an inpatient or later in an office situation, you would count those when you're reviewing those ER notes, you would count those and you can count those tests. As long as they're, unique tests, you wouldn't count them more than once. Next question.
All right. Can you repeat what can be counted towards data when a patient wants a procedure, but the physician considers it and determines it's not medically necessary? How would that be viewed?
Well, what I had stated was if the patient comes in and says they want an MRI scan, for an example, and you know that that service is not medically necessary for that patient, you can count that discussion of why that patient and why they should not have it, why you're not going to order it as part of your documentation, and you can count it as an element of your data under the category 1. For a procedure, that would not, and let's make sure we're using the same terms. When I'm using the terminology procedure, I'm thinking more of a surgical procedure, an injection into the knee, something along those lines. That would not fall into the data category. That could go into your risk category, but that's for another webinar. Next question.
Say a provider orders a chest x-ray, does an independent interpretation, but they would not be billing separately for the X-ray. Can we give credit for the order and the independent interpretation?
Yes, they can get credit for both the order and that independent interpretation. They would not get credit for both the order and just a review, but if they're doing the order and the independent interpretation, that counts for both, excuse me, for both categories.
All right.
Next question.
If the provider sees a patient for 2 chronic illnesses and the documentation states patient is stable, would this be 99214?
Okay, that's not a question that we're going to take during this presentation. That has to do with problems and the problem element of the MDM, and we're going to stay with data today.
All right.
Next
So this next one's a unique question. Our physicians will attend a tumor conference each week. If the physician states patient's case was discussed at tumor conference and gives some detail about what was discussed, would this count as discussion of management in the data column when the patient comes in for their next visit and the physician goes over what was discussed with the patient?
I think that one is a very good question, and I'm not going to be able to answer that one. What I would ask that individual to do is to send that question in to our education email box, which we'll share in just a second, and kind of give us some more information about exactly what's happening there, and then we'll be able to respond to everybody. Because I don't want to give an incorrect answer, but I need more information on exactly what's happening there. Next question.
All right. So would a parent providing history for a 16-year-old be sufficient to qualify for independent historian?
What your documentation would have to show when we're a 16-year-old is why the patient's information is not reliable. Now, obviously, Medicare doesn't deal with a whole lot of 16-year-olds, but the documentation has to support why you could not take that information from that 16-year-old.
All right. So if a general surgeon is consulting a patient just admitted from the ED and he documents that they reviewed the ED notes, pulled lab results in from the ED with notation that the note was reviewed, and documents the analysis of one of the ED labs, credit be given for the review of an external note and the review of the results of each unique test?
Yes. They can count both of those.
Okay. So our next question is about the independent historian age. I'll ask it, but it might not be super geared towards Medicare. What is the age of a child considered necessary for an independent historian? You stated for an adult, you would need to state why it was medically necessary. So could we give credit for any child up to the age of 18?
No, when I'm not going to be able to give an exact age on that. Part of that's going to be your physician's determination as to whether or not that child can provide reliable and complete history. If that clinician's belief is that they cannot, then they can bring in somebody else. And get that information from someone else. But Medicare does not have any ages that would attach to that.
All right. The hospital some hospital codes do not have a CPT code. In this situation, how can we count those services as an independent interpretation?
Okay, well, the procedure code, I mean, there will be a procedure code for the service. You know, whether it's telemetry or something else, if on the professional side of that, there's a procedure code. If there isn't a procedure code, you know, then you haven't ordered a test because the AMA talks about the procedure codes and that type of thing. If you're doing an interpretation of that and there isn't a procedure code, then you would not count it. If there is a procedure code for the professional side, then you can count that as either a review or an independent interpretation, depending on which one you're doing.
All right. If the discussion of management doesn't count until it is concluded, what date of service would you count it on?
It is still part of the data service for that patient encounter. So you start talking, you know, patient encounter is on February 13th. Your doctor starts that conversation on the 13th. It concludes on the 15th, that exchange of information. It is still part of the 13th date of service.
If a provider reviews data that equates to a CPT code which contains services bundled into the E&M, can the provider capture the review of this data as a Category 1 element because they are not trying to bill the other CPT codes separately?
If there's a procedure code for the data that indicates that professional interpretation, and you're not billing that procedure code, then even though it could be part of the National Correct Coding Initiative, you can still bill that as an element of your data. Or include that, let me put it that way, include that as an element of your data.
Right. A hospitalist asks for a cardiologist consult. The cardiologist performs a consult and notes the discussion that they had with the hospitalist in the note. Can this be counted as discussion of management?
For who? For the cardiologist or for the hospitalist? Because when you're requesting a consultation, you're really already, you know, kind of doing that. So what we would need to look at in the documentation is who requested that discussion. How does that play into the medical decision making for that particular patient? This is also a question, if you would, to send into our education mailbox and kind of provide some additional information about what is actually happening, and then we can respond to everybody on this question.
All right. So if a review of an ER note was done in your facility, but family practice is now reviewing the notes, can this be counted since different specialties are reviewing the notes, even though they're from the same facility?
Okay, if I'm understanding the question correctly, we have two different specialties who are treating the patient, and both of those specialties have reviewed the notes from the last ER visit. Both of those providers could count that as review of external notes. If I'm not understanding the question correctly, then again, we would ask that you submit that to our education email box.
All right, I'm just trying to get down
Okay.
to, okay, so can credit be given for data ordered if a test is documented to be ordered, but an order is not placed for that same day, but instead it is placed 2 weeks later.
Yes, because your doctor has done the work to determine that that test needed to be ordered. And, I mean, things happen, the patient may not have taken the order with them or, whatever, and you have to, do that 2 weeks later. You still did that during that encounter. So yes, that can be counted.
All right, and then similar question from the same person. Can credit be given for data ordered if a test is documented to be ordered and the order is placed within the RCU period, but not the same day as the visit?
And the answer to that is yes. And what they're talking about there is the the RUC, um, and that's a whole nother webinar thing and a whole nother topic. But in a nutshell, that kind of incorporates the amount of work and how they use that. CMS uses that in order to determine the pricing that has no effect on how you're going to choose your level of service.
So if a physician provides services at a skilled nursing facility and notes that a specific lab will be ordered, but the order isn't entered in our system, can we count it? We are assuming that it is ordered with the SNF.
Yes, you can count it because that's work that your physician is doing. They have determined they need the results of this particular test in order to adequately and correctly treat that patient. So yes, you can count that. Anything else then, Rachel?
Nope, that is all the questions I see.
Okay, so on behalf of myself and Rachel Wood and our WPS Government Health Administrators Provider Outreach and Education Department, we really appreciate the time that you have spent here with us today, learning more about data and being able to ask your questions. As I stated earlier, this should be available on our Encore website, which is part of our website under the Training Center, probably within the next week, and then also available on our YouTube channel. So again, we just want to thank you very much for attending. We do ask you to complete the survey if you haven't already, and this concludes our presentation. Have a great day, everyone.